Welcome back. Here to finish up the third part on our urinary system. We're going to begin with the countercurrent mechanism. And so starting to look at how we actually create this concentrated urine as we're moving through the tubules themselves. That is there. And so when it comes to talking about the concentration that we have there, the kidneys themselves have a tremendous ability to increase the concentration of the blood for urine up to about 4 times what it normally is in the urine itself, or in the blood itself rather. And so normally the blood is looking at 300 milliosmoles as far as the blood concentration is concerned, and the kidneys can take it up to about 1200 milliosmoles. And so we have an ability to get it up there fairly concentrated. And then on the flip side, we can also create relatively dilute urine down to about 50 milliosmoles as well. So we have quite a bit of a range in terms of the ability there to create this concentration. And it comes down essentially to, once again, we have our glomerulus and the capsule. We come down, we come out of our proximal convoluted tubule to go down the loop, back up the distal convoluted tubule, and on. And as we go through there, remember back to when we were talking about the blood vessels, the vasa recta is connected to our efferent capillaries that come out of the capsule there. And that vasa recta connects the two sides essentially of our loop of Henle. And so that creates this ability to again go from essentially up here where it's coming out and it's at about a 300 to where we're down at the bottom, we're at around 1200. And if we want to, we can get it down to about 50 or so as it comes down through the remaining components of the collecting duct itself. And so we can change those amounts quite a bit if we really need to. And it's all partially due to that countercurrent mechanism that we have there. And so we're creating this process where as we go down one side of the loop of Henle, we're creating a more concentrated solute that's inside the tubules themselves. And then as we come back up, we're creating a less concentrated component there as well. And so we create this kind of step in a sense where we have different gradients there of the concentration of our solutes that are there as we move through the tubules themselves. And so we get this kind of stepping process that is there for that. And this relies upon the fact that as we looked at the different parts of the tubules themselves, we saw that different types of substances were able to move in and out of the tubules. And so that descending loop of the loop of Henle was primarily permeable to water. And so we were pulling lots of water out. So as we pull that water out, the concentration goes up. And then as we come back up the loop of Henle, this one is now permeable to solutes and impermeable to water. So now we're going to leave the water in there, but we're going to take the solutes out. So that effectively makes it so that the precipitate that's inside the tubule is a lot less concentrated at the top of the ascending loop than it was down at the bottom of the loop itself that's there. And then as we move down or up through the collecting duct and start to move down towards the bottom of the medulla in a sense, that's there, we're then able to alter the concentration by either taking water out or in urea out of the collecting duct to allow for that concentration, the final concentration to be had as we create the final product of urine that is there. So this vasa recta, this countercurrent mechanism that we have there, essentially creates it so that we have those varying levels of concentration. And so that we have different amounts of concentration all the way down through the loop of Henle itself. And we create the system of gradations that are there all along the loop that's there. And then coming along with it, we then have the blood vessels of our peritubular capillaries that's there. And this then essentially equals what's inside there. So if we were to look between the two, we'd have, in a sense, the loop, and then we would have the blood vessels that are there, the capillaries, and our vasa recta. And as we look at the concentrations that are there, we're going to have roughly the same concentration in the capillaries as we have in the tubules. 500 there, and then down to 1200. And so they're going to basically mirror one another as they come around. They're not going to be exactly the same, so we're never going to have a complete equilibrium between the two sides of the system itself, but it's going to be pretty close. And so here we have those loops that are there. We can see that inside the tubules on this side here, we start out with that 300 milliosmolar, get down to around 1200 down at the bottom there, and then we come all the way back up and we reverse the process, and so bring back the concentration to a lower amount, and we have the ability to get that down well below what the blood was of 300 and down into 100, and then at its greatest amount, if we wanted to continue to make even diluter urine, we could then get it down to around 50 milliosmoles on the way out. And the same thing there we see with our arterioles, or the efferent arteriole and our vasa recta. We've got roughly the same concentration in the blood as we have in the tubules themselves. So that creates that kind of stepping process that is there. So we essentially make, in a sense, kind of two general types of urine: dilute urine and concentrated urine. And so if we're going to make dilute urine, that means that we need to have essentially all of the solutes out and leave basically just water inside the urine itself. But it's not going to be only water. We still need to be able to get rid of all of those nitrogenous wastes. So we have to make sure that we still have the nitrogenous waste in there. It's just going to be that there's going to be copious amounts of water in comparison to that of the solutes that are there. So lots of water, very little solutes that are happening along there. So as we move down through the tubules themselves, and we're diluting things as we come up that ascending loop, the dilute urine is then essentially further diluted as it moves into the distal convoluted tubule and into the collecting duct on its way down. And so if we have a situation here where we're creating this low urine, one of the factors that's going to play a role in that is antidiuretic hormone. And so if antidiuretic hormone is there, so antidiuretic, antidiuresis, and so against creating water for urine that's there, when we have ADH being expressed, that ADH is going to cause more of a concentrated urine rather than a dilute urine. The collecting ducts themselves, as we're trying to create dilute urine, are going to be impermeable to water, so they're not going to allow water to come in from the tubules themselves, and that's going to allow it to be essentially lost as it moves through the collecting duct itself. That's there. We can continue to do some reabsorption, and so we can reabsorb some of our ions that are there, and allow those to kind of come back in through the tubules into the capillaries, so that, as I said before, we can get down to about 50 milliosmoles inside this very dilute urine that's there. On the opposite end, we have concentrated urine, and so antidiuretic hormone itself gets released. One of the things that can inhibit it to make all of that dilute urine is something like ethanol or alcohol. And so when somebody has alcohol, one of the reasons why their urine becomes dilute, if there's not really much volume that's being consumed, is simply because of that blocking of antidiuretic hormone itself. And so without that present, we get that dilute urine. And with it present now, so if we're going the opposite direction, this is going to increase the reabsorption of water back into the body. And so when we get ADH being released, almost all of the water is reabsorbed. So we can take back in essentially 99% or so of all of the water that was out there in the filtrate, and that's going to be brought back into the capillaries and saved. So we create a concentrated urine and lose very little water in the process. We still again get rid of the waste products. We're still going to get rid of all of those nitrogenous wastes out of the body, but we're going to keep all of the water, at least as much as possible, that's there. And this is where essentially that countercurrent mechanism really comes into play here. And so down at the bottom of the loop of Henle, we created a 1200 milliosmolar concentration of the inside the tubules. And now as we come down those collecting ducts, we have the ability to essentially equalize it to that 1200 milliosmoles. So we've got ADH present. We're inhibiting the loss of water by causing the reabsorption of water in through the distal convoluted tubule and the collecting duct there, and we're pulling all of that water back into the system, making it so that we don't lose any of it in the process. Diuretics from there have the ability to create the dilute urine component that we want. And so a diuretic itself, it can come in many different forms. We've possibly heard of diuretics before, or know of some common diuretics that may cause diuresis, may cause the production of excess water that's there. But what's actually happening when we have a diuretic in our diet in some way that's there? So a couple of different things can cause diuresis to occur. And so any substance that's not reabsorbed. So here we can think of things like glucose. So in a person who is a diabetic, one of the reasons why we lose water, and so why they have polyuria there, is because of the glucose that's being lost into the urine. And so that glucose is in high concentration in the tubules that pulls water towards it. And so they end up having the water released into the urine rather than holding it. So then they have the polyuria, and then in the process they also then get polydipsia as well. If we have other substances that have, and glucose really kind of falls under more of the exceeded the ability of it to be reabsorbed, rather than something that is completely not reabsorbed whatsoever. And so something that we don't have that ability to pull back in. Glucose falls under the case where we have too much of it, and so it gets stuck in the tubules. And then if we go into anything that then can inhibit sodium reabsorption, and this is where a lot of the medical or the prescription types of diuretics come into play, as far as things go into the mechanisms, is some of the earlier ones were based upon sodium reabsorption rather than anything else. So with that, high levels of glucose, so lots of glucose in the body. We can inhibit ADH through alcohol. So alcohol causes ADH to become blocked, and that inhibits its release. So even if a person was already dehydrated and then they go and they have alcohol, they're going to continue to become dehydrated because that ADH is going to be inhibited, and they're going to make lots and lots of urine in the process. Caffeine, something over the counter in a sense again as well, causes excess amounts of urine production, and that urine production is again because of its blocking of sodium reabsorption. And so we have things that are going to work against that sodium. Where the sodium goes, the water follows. So if we're bringing that sodium back into the body, we retain the water. If we're blocking that sodium from being reabsorbed, we're going to lose it, and we're going to become more and more dilute as far as the water that's being produced. And this is the same concept that prescription drugs fall under as well. And so we have things like Lasix and Diuryl as sodium blockers also. So that'll cause that loss of sodium. Others with those will oftentimes end up losing potassium at the same time. So we have things that are going to allow us to spare potassium in terms of medications as well that are there. We talked about ethanol, we talked about caffeine in terms of diet, other kind of natural foods as well. Mentioned asparagus earlier on in terms of the urine production as well. And that's why your urine starts to smell of asparagus if you've had it. Other things, corn silk, so the little hairs on corn, dandelion root are both pretty good diuretics as well that can cause diuresis naturally also. So where's that all occurring? Essentially throughout the loops themselves. And so our Lasix, our Diuryl, are referred to as loop diuretics because they're inhibiting the uptake of sodium along the loops themselves that are there. Those potassium sparing diuretics, these are going to work later on in the process and block the reabsorption of sodium at that point. Another aspect of renal function is that of renal clearance. And so how well can the kidneys be functioning at any given time? We talked about it in terms of GFR earlier on. And GFR allows us to, or gives us an idea of the amount of filtering that is happening with the kidneys themselves. But again, that one's really kind of hard to measure. So rather than looking just at the kidneys and the urine output, we're going to look at both urine and blood here with renal clearance. So we're going to look at the volume of the plasma that is being cleared of a particular substance, meaning what's the level of it in the blood and what's the level of it in the urine. And so we're going to look at those aspects of a particular substance. And so we can look at our blood urea nitrogen. We can look at creatinine as both substances that we can look to as far as things that the kidneys clear and look at the difference between the two. That's there. And so this is going to be an indirect determination of GFR when we find there. This can help us to look at kidney damage. This can help us to look at kidney disease. Is it progressing? Is it getting better? Is it getting worse? Depending upon the person. Do they have acute kidney failure? Do they have chronic kidney failure? Things like that. And we can kind of monitor the progress from there. So renal clearance is going to have to, we're going to have to look at two aspects. And so in order to get renal clearance, we're going to have to see the concentration of whatever substance it is that we're looking at in the urine. And we're going to look at the concentration of whatever that substance is in the plasma. That's there. In addition to that, we're going to also look at urine output. And so what's their flow rate? So the V there is the flow rate, milliliters per minute. So we're going to have to do something like a 24-hour catch, a 12-hour catch, and monitor how much water they're actually producing within that period of time on there. When we take a urine sample, so we can look at it and look for particular substances in the urine for their concentration that we find. And then we can look at the concentration that we find in the blood. And that's going to give us an idea of the kidney's function. Other things that we can look at are just simply the urine itself. And so what's actually in the urine, what are the characteristics of the urine itself when we see it? So we've all seen urine before. And so we kind of know what it looks like when it's fresh. And so it has kind of a pale yellow type of a color to it. It is clear. So we do want it to be clear, not cloudy whatsoever. And it's going to have any range of color of basically yellow all the way up to clear and no color, depending upon the concentration of the solutes that are inside there. on there. So concentration itself of the solutes determines the actual shade of the color rather than the clarity that's there as well. Color can be altered by things like vitamins, mineral supplements, drugs of different kinds can cause the color to create a different color to it. But again, we don't want to see it being cloudy. Cloudy means that we have large particles inside there. We've got large solutes inside there, generally going to be indicative of things like that of bacteria, possibly white blood cells, proteins, things that are very large, causing that cloudiness to the urine itself. Urine's odor is going to be slightly aromatic because we've got things like our urea inside there. We've got our nitrogenous wastes that are inside there. Perhaps the odor is altered a little bit by things like the things that the person is consuming. Perhaps they've had a bunch of coffee. Perhaps they've had asparagus. Maybe they took a large B vitamin. Things like that can all alter the odor of the urine itself that is there. And so that can create a change there in the overall aromatics for things. From there, if we leave urine out, we have the ability to it does start to form ammonia when it is there, but when we have fresh urine, it's not going to have that ammonia smell to it when that happens either. pH is going to be slightly on the acidic side. This is going to help with things like inhibiting bacterial growth, so that person doesn't get a bacterial infection that's there. Things like diet, things like metabolism can alter the pH that is there. Somebody's having is a diabetic. Things like that, they can become more acidic. If somebody is on a ketogenic diet, they're going to produce acids as well, and so that's going to change the overall acidity of the urine as well. Specific gravity is not one that's used quite very often anymore, but it is something that is typically on a urinalysis as well. This is the solutes themselves and their overall concentration that is in the urine itself, and it relates to the overall concentration of everything that's there. So it's not very specific in terms of giving us an idea of one thing or the other inside the urine. Urine is going to be almost all water, and so there's quite a bit of water there and a little bit of solutes. When we look at the urine itself in terms of its contents, we have our nitrogenous wastes, the urea, the uric acid, and the creatinine. Those are our three that we have to get rid of. Those are our normal metabolic wastes that we have for things. Other things we're going to see are things like water-soluble substances, and so all of our ions, potentially water-soluble vitamins if we've had too much of one in a short period of time, things like that. All of that can be elevated inside the urine as well, depending upon what our diet and things like that have occurred in there. If we look at any one and we can't explain it by diet or supplementation, things like that, that may indicate that there's some sort of pathology happening in the kidneys themselves. And so in either the glomerulus, in the tubules, somewhere along the way, we're having some problems with that. Beyond the kidneys, we move into the ureters. The ureters themselves are just tubes, essentially. Those tubes get the urine from the kidneys down to the urinary bladder, where it can then be stored. And that's then going to allow for keeping the urine there until essentially you're ready to urinate. So that we're not just kind of dribbling out urine all the time. That's where the bladder comes into play. The ureters themselves are muscular, so they are actually going to squeeze kind of the urine as it's coming down into the bladder itself. This is also going to help with decreasing any kind of movement of the urine back from the bladder into the kidneys so that we don't have any retrograde movement of the urine once it's there. So 3 layers, smooth muscle in the middle, transitional epithelium on the very inside, so lining the actual lumen, and then fibrous connective tissue and adventitia surrounding the outside. That is what we would see if we were to look inside the abdomen itself. They contract, they squeeze the urine down towards the bladder itself. Another reason why, in a sense, when somebody has a kidney stone, oftentimes their pain comes in waves. So here we can see an image of the kidneys. We have the ureter coming down from the kidney, going down to the bladder itself. On this one, this is an interesting one because there's actually 2 ureters. And so this kidney has 2 ureters. It's a fairly common anomaly to have a duplicated ureter that's there. Sometimes they will close off on their own. Sometimes they'll require a surgical approach to remove the extra ureter that's there, or at least to clamp it off and make it non-functional again, because it does increase the person's likelihood of getting a urinary tract infection. So once the urine leaves the pyramids, it's all done being modified. And so the urine that goes down from the kidneys through the ureters to the bladder, it's not going to be changed at all. It's not going to be concentrated at all. It is the final product. And so the bladder is just a holding chamber. And so similar to that of the ureters, it does have 3 layers to it, one of which is the smooth muscle on the inside that is there. It is retroperitoneal, so it is inside the pelvis and it's retroperitoneal that is there, and it's just posterior to the pubic symphysis. The difference, in a sense, between males and females as far as the bladder goes, the male bladder is a little bit larger. The female bladder does not have the ability to get as large simply because the vaginal canal is impeding its expansion there posteriorly, and then superiorly the uterus is kind of stopping its ability to expand as well. So we do have kind of a difference there between males and females. The other difference is that in males, at the opening of the urethra, extending from the neck of the bladder itself, you have the prostate gland. So the prostate gland is the kind of the first portion right out of the bladder for the male. For the female, it's just running right through the urethra, and that's it. The inside of the urinary bladder has, I thought I had a picture here of it. The inside of the urinary bladder looks something like this. And then that's the opening of the urethra. And there's this triangular structure called the trigone. And the trigone is a space where we don't have any transitional epithelium, so it's not going to stretch out there. Only in this trigone here, we don't have the transitional epithelium, and it's going to help to maintain the structural integrity between where each of our, we'll go out this way, I guess, each of the ureters enter into the bladder, and then where the urethra begins coming out of the bladder itself as well. And so that kind of triangular area there is squamous epithelium, and this can be the site of kind of the origins of urinary tract infections. That's there. So this part doesn't stretch out. This doesn't move or anything like that in that area. But the bladder does expand as we fill it with urine. So here's the trigone here in the female. Here's the trigone here in the male. That's there. You can see the prostate there in the male as well, and no prostate in the female. One of the other aspects here is that the male's urethra is much, much longer than that of the female, making the female more prone to urinary tract infections because any kind of bacteria that may be growing in there has a much shorter distance in the female to get back to the bladder compared to that of the male. So more than likely in the male, by the time that that bacteria may be starting to get close to the bladder, they would then void again, and urine will then flush all of that bacteria out of the urethra. Whereas in the female, that bacteria may have made its way into the bladder before they ever have a chance to urinate and have it go out from there. Both of the bladders will expand, but again, the female bladder is restricted a little bit in terms of its expansion based upon the other anatomy that's in the area, that being the vagina and the uterus. So the bladder is basically a big muscular sac. And then continuing from that, we have the urethra, which is a muscular tube. And so this one again is going to help to force the urine out of the bladder or drain it from the bladder once it's out of the bladder itself and move it out of the body. So we don't want to, again, have any kind of retrograde movement of anything once the urine has left the bladder itself. For urination to occur, we have two sets of sphincters. There's an internal sphincter and an external sphincter. These two have different components as far as their control. So the internal sphincter is involuntary. The external sphincter is voluntary. So we have control over that external sphincter. We don't have control over the internal sphincter. So when we need to urinate, the expansion of the bladder causes stretching on the bladder itself, which then leads to a involuntary relaxation of the internal urethra. But if we are potty trained, then that external urethra can be remained contracted along with that of the levator ani muscles, and this is going to essentially close off the release of any kind of urine until we relax those external sphincter muscles as well as the levator ani muscles as well. So the urethra itself, as I said, a little bit different between the male and the female. The female is shorter. It's held in place in a sense to the fact that it's tightly bound up against the vaginal wall that is there. And it only has a little bit in terms of getting out of the body in terms of its length that is there. For the male, the urethra is much, much longer. It runs through the prostate. It runs through the penile tissue that is there. And so we end up with three basic regions to the urethra in the male. We have the prostatic urethra that runs through the prostate. We have the membranous urethra that runs through, it's relatively short and goes through the urogenital diaphragm. And then lastly, the longest section is the spongy urethra. This is going to move through the corpus spongiosum of the penile tissue that's there. And so that length there allows for a decreased susceptibility to urinary tract infections in males compared to females. So micturition or urination is a voluntary process as long as we can control that external sphincter for the muscles themselves. And so as the bladder expands, and so as the bladder is expanding, so we have information coming in here on this side that is telling the spinal cord that the bladder is starting to expand. And we're going to then alter the sphincter muscles that are there. So when the bladder is deflated, it's going to essentially keep those muscles nice and tight. As the bladder expands and stretches, that sends signals into the cord. Those signals go and make their way on up, and that gets to the micturition center inside the pons. As the pons then send signals down, that's going to send signals to the bladder to cause contraction. And so we're going to get contraction of the smooth muscle of the bladder itself that is there, because we're going to inhibit the sympathetic fibers. As those sympathetic fibers are inhibited, that decreases the inhibition of those smooth muscles in the bladder. From there, send signals down to the cord, and as those signals come down through the cord, again, going to cause contraction of the bladder muscles, as well as that of relaxing the internal sphincter. And if we're not potty trained, relaxing the external sphincter as well. And then we just start to urinate. That's there. The further, in terms of age that we get, and we become potty trained, that signal continues on up and we have sensation that our bladder is filling. And if it's not time to go yet, we're just going to simply continue to contract those external sphincter muscles consciously and not allow the urine to escape until we're ready to go. Because the kidneys do concentration of solutes, we have the potential for kidney stones to develop. And so these are going to form in the kidneys rather than in the bladder like we get with gallstones and the gallbladder that is there. Fairly equal in terms of males and females, but the content of the actual stones themselves can vary based upon the sexes. Again, those that are in terms of females that are getting more urinary tract infections, they may be produced by struvites. We may get uric acid types with those that are on a high protein diet, so high protein, but your body's not able to utilize all that protein. We may see that there. The stones themselves can be quite large. They can be very, in a sense, jagged when we see them. And so this goes along with the quantity of pain that we see with kidney stones as well. That's there. This one here is actually one that you can see. This is essentially the pelvis, the renal pelvis, and then we have the openings back up towards the medulla there. And so we have a major calyx, we have minor calyx over here, and so on. So they can become quite large. Here, another one inside the renal pelvis there. Pretty large stones at different times. Overall, the function of the kidneys is meant to last a lifetime, but their ability to concentrate things does change over time as well. And so as infants, infants don't have the ability to concentrate urine very well. They also have a relatively small bladder. So this is why kids do have to go to the bathroom more often than that of adults for them. So they can't hold the urine quite as long because of that. We do eventually get the ability to control those sphincter muscles that are there. And in terms of kidney function, it's going to be well for the majority of our life. And then with age, essentially the kidneys themselves are going to start to decrease their ability to concentrate quite as well again. And that's going to then kind of lead to some issues there, as well as the potential of not being able to control the sphincter muscles or possibly the pelvic floor muscles very well, and that can then lead to incontinence as well. Sexually transmitted diseases throughout the lifespan as well are potentials, and these can cause all kinds of issues with the urinary tract, and we'll talk about those more in depth when we get into the reproductive system itself. And that ends our talk on the urinary system.